In this lecture, we're discussing drugs that are used in general anesthesia. And so general anesthesia includes not just loss of consciousness, which I think everyone associates with anesthesia, but also there is an amnesia component, immobility and the inhibition of reflexes, analgesia, and also muscle relaxation. We are not going to discuss the muscle relaxants in this section, but we'll touch on drugs that accomplish all of these other features. In rare cases, a single drug will be used for general anesthesia, but typically it will involve a combination of drugs and a combination of inhaled gases or volatile liquids and intravenous injectable drugs. So one of the first general anesthetics that was discovered is ether, and it was used for surgical procedures, but also recreationally for a long time. And ether was a slower acting anesthetic than the drugs that we use today, but it was helpful in defining the different stages of anesthesia. So in the drugs that we'll be discussing, for the most part, they're going to act very quickly, and so we don't see the individual steps. But these slower anesthetics establish the different stages and levels of anesthesia. So the first stage, as general anesthesia is just beginning, there's the stage of analgesia where there is decreased awareness of pain, and that's followed by a sort of counterintuitive phase of excitement or disinhibition. And so in this stage, patients become delirious. They can also have amnesia, but they have enhanced reflexes. They can experience vomiting and incontinence and irregular respiration, which is very dangerous. As patients go deeper into the anesthetized state, they now lose consciousness and lose their pain reflexes. So this is obviously a good thing for surgical anesthesia. The blood pressure and respiration are still regular at this phase of anesthesia. So this is what we call surgical anesthesia. This is the goal. So in order to maintain this state, patients would be monitored for their reflexes, vital signs, EEG activity, and respiratory and circulatory responses to surgical stimulation, so pain stimulation. If patients go deeper into the anesthetized state, this is where you would experience severe respiratory and cardiovascular depression. And this happens by inhibiting the vasomotor center of the medulla, and so circulatory and respiratory support would be required. So the underlying goal of initiating general anesthesia is to get down to the surgical anesthetic state very rapidly so that this excited state is minimized. So we want to use a strong and a fast enough general anesthesia to very quickly reach the surgical anesthesia. But then, of course, we have to make sure that we stop here, because if we go further, this is where patients can die. So speed and controlling the strength of the anesthesia is a major clinical goal. Here are the drugs that we'll be discussing in this lecture, and they're organized by their mode of administration. So the inhaled anesthetics include the gas nitrous oxide and also liquids that are highly volatile, so they will give off gas that can be inhaled. And all of the volatile liquids are listed here. We'll also discuss several IV anesthetics, and they have different chemical and structural classes, and some of them have quite different mechanisms. Aside from those few exceptions, the general mechanism of action for general anesthetics is to overall depress neuronal activity, and they do this primarily by enhancing the activity or the opening of GABA A ligand-gated ion channels. This again is the primary, GABA itself, the neurotransmitter, is the primary inhibitory neurotransmitter in the brain. They are very widely expressed, so most neurons are going to express GABA A receptors, GABA A channels, which are again ligand-gated ion channel receptors. And so drugs that enhance GABA opening will inhibit neuronal firing. So all of the inhaled anesthetics and several of the IV drugs, including the barbiturates, benzodiazepines, Etomidate, and Propofol, all have this GABA A channel mechanism. And so All of them are going to make the endogenous neurotransmitter GABA do a better job of opening the channel, and many of them can actually cause opening of the channel in the absence of GABA. In addition to the GABA-A mediated mechanism, which is the very well established mechanism, it's also possible that some of these drugs can also activate glycine-gated chloride channels and can inhibit excitatory channels like nicotinic receptor cationic channels and NMDA glutamate channels. But primarily the mechanism we should focus on is enhancing GABA-A activity. So there are two main exceptions to this mechanism, and these are both IV general anesthetics and kind of not very widely used ones. So these are special cases. Ketamine has a very unique mechanism in that it antagonizes the NMDA glutamate receptor. So this is an excitatory channel, and antagonizing it would cause inhibition. And then we just spent a lot of time talking about the opioids as analgesics. They can also be used in the context of general anesthesia, but again, the mechanism would be through their activation of the opioid receptors. So since the GABA-A ligand-gated ion channel is the target of most of the general anesthetics, we'll spend some time talking about this receptor. Again, GABA is the neurotransmitter. It's an amino acid, and it's the major inhibitory neurotransmitter in the brain itself. In the brain stem and in the spinal cord, glycine is a major inhibitory neurotransmitter. GABA-A, again, is a chloride ion channel, and it's gated by GABA binding. And the channel itself is composed of 5 different pore-forming subunits. So these 4 subunits come together and form the big donut in the plasma membrane. And these 5 different subunits are heterogeneous. So the combination of specific subunits used to make the complete channel is going to vary by brain region. So they have different alpha, beta, and gamma subunits pieced together in different ways to make distinct different versions of the GABA-A channel. The anesthetic drugs that we're talking about are going to bind to specific sites on the alpha and beta subunits of the channel, and it's an allosteric site, meaning it's not the same site as the endogenous neurotransmitter GABA. So several of the drugs are going to potentiate GABA's action. So, for example, the benzodiazepines increase the frequency, and the barbiturates increase the duration of GABA-mediated opening of the GABA-A channel. In addition to helping GABA work, all of them except for the benzodiazepines can also bind and directly cause the channel to open even in the absence of GABA. So since benzodiazepines cannot do this, in general, benzodiazepines are a weaker activator of the GABA-A receptor. And I'll remind you that GABA-B is a G-protein coupled receptor for the neurotransmitter GABA. These drugs do not bind or activate GABA-B. This is an independent receptor. So this is the schematic of the GABA-A receptor. It's not showing the individual subunits, but again, this entire protein channel would be composed of different subunits. Here you can sort of see the lobes, 1, 2, 3, 4, and there are actually 5 different subunits that make the intact GABA-A channel. What's shown here is that the GABA binding site and the drug binding sites for barbiturates and benzodiazepines, for example, are distinct. So you can get simultaneous binding of the endogenous GABA neurotransmitter and the drugs, and this is how they help GABA work. So since GABA is a universal transmitter, it functions as an inhibitory neurotransmitter in all parts of the brain, and these drugs are hitting the GABA-A receptor, which is, again, very broadly expressed. How are the effects of these drugs that activate GABA selective? So how are we not shutting down neuronal signaling and all neurons at all times, since essentially all neurons express GABA-A receptors? Well, the answer is that different parts of the brain express different versions of the GABA-A neurotransmitter based the GABA-A receptor based on differential subtype inclusion. So they are heterogeneous, so they have different subunit composition. And so that the GABA A channels in different regions of the brain have different sensitivity to the anesthetics. And so walking through the levels of sensitivity of different brain regions to anesthetics recapitulates the stages of anesthesia. So let's walk through that. The most sensitive neurons, the neurons that are most sensitive to general anesthetic, activation of their GABA A receptors, and therefore they're going to be inhibited at the lowest levels of the general anesthetics, are dorsal horn neurons, which carry pain signal. So again, pain transmission is the first thing that will be lost as you start undergoing general anesthesia. And this corresponds to stage 1 of anesthesia when you have analgesia, and you can also experience conscious sedation. The second most sensitive neurons are small inhibitory neurons. So again, if the anesthetics are going to cause an inhibition of these neurons, this gives you disinhibition and therefore corresponds to the excitatory stage of stage 2 anesthesia. And finally, in stage 3, which is the stage that we're looking for, that we're trying to achieve in general anesthesia, this corresponds to inhibition of the third most sensitive set of neurons, and these are the ascending pathways of the reticular activating system that control the sleep-awake cycle and spinal reflex activity. So this is where you have loss of consciousness, loss of reflexes to pain and stimulation. And finally, the least sensitive parts of the brain to inhibition by general anesthetics are the respiratory and motor centers of the medulla, and this is why as you increase the exposure and concentration of general anesthetics, you achieve these 3 stages first, and only if you continue to increase the dosage would you reach stage 4 of cardiorespiratory collapse. So again, our goal in administering general anesthetics is that we want to very quickly pass stage 1 and stage 2 and get to stage 3. It's where we have inhibited these sleep-wake cycle neurons, but we don't want to go past that and add so much of the anesthetic that we inhibit the medulla, respiratory and vasomotor centers. Okay, so we'll talk first about the inhaled anesthetics, and again, this will include the gas nitrous oxide, shown here, very simple molecule, and several volatile liquids, which again exist in liquid form but readily give off gas, and so they can be inhaled. You can see that several of the volatile liquids, you can sort of see the underlying structure of ether. So ether would be carbon, carbon, oxygen, carbon, and then another carbon here. And so most of these are halogenated derivatives of an ether backbone, except that one of the carbons is gone. So again, highly halogenated, you have chloride and fluoride ions. These can lead to some of the toxicity that we'll talk about. So the administration of the inhaled drugs requires us to think about the pharmacokinetics in a very different way than oral or injected drugs, because the drug is going to be administered by respiration. So you have a source of the gas drug or the volatile liquid that's going to be inhaled, so it goes first to the lungs, and then from the lung to the blood, and then the blood of course carries it to the brain, which is our target. So the transfer of gas from the alveoli in the lungs to the blood is going to depend on several features, and again we're going to want to pay attention to all these because we are very concerned with how quickly we will establish the general anesthesia. So we want to think about the speed of establishing analgesia and anesthesia. So again, it's the concentration in the central nervous system that will determine the anesthetized state, but we have to start first in the lung and then go through the blood to get there. So the primary driver of the parameter that primarily determines the speed of action of a drug is going to be the solubility. And so then it's a little counterintuitive. So when we talk about solubility, we're talking about the solubility of a gas or a volatile liquid into the blood, and that's defined by the blood-gas partition coefficient. And again, somewhat counterintuitively, a low blood solubility will give faster central nervous system action. And so the blood is basically a barrier to the central nervous system, so the more highly soluble the drug is in the blood, the slower it will be. So for example, nitrous oxide and desflurane and sevoflurane, not listed here, are examples of inhaled anesthetics that have very low solubility in the blood and therefore are very fast acting. On the other hand, halothane and methoxyflurane have very high solubility and are very slow acting. The other way you control the speed of general anesthesia is simply by increasing the concentration. But again, the concentration of an inhaled drug is somewhat different. It's defined by the partial pressure of the gas in the air. And so this can be reported as a fraction of the total gas mixture. So you can have, for example, 50% nitrous oxide. Or this also can be reported as an absolute partial pressure. So for example, 760 millimeters of mercury is atmospheric pressure, and so if you had 50% nitrous oxide, that would also equal 380 milligrams of mercury. So in this case, the relationship makes sense. If you increase the concentration of a particular inhaled gas in the source that's being administered, that will increase the rate of onset. So you can drive a faster onset of anesthesia by simply increasing the concentration in the source that's being applied to the patient's respiration. So this can be helpful for drugs, for example, like some of these high solubility slow drugs like halothane. You can simply give a very high concentration initially to rapidly get them to the brain, and then you would taper off as the maximum level of anesthesia was achieved. Lesser parameters that we'll talk about less is the ventilation rate. So the higher the ventilation rate, the higher the uptake, and this again is important with high solubility drugs. So if you have a high solubility drug that's going to be slower, you can try to increase the ventilation rate to make it faster. Also important with respect to this is that the opioids can depress respiration. You're very aware of that now, and this can slow down respiration and also make inhaled anesthetics act more slowly. Things that increase pulmonary blood flow will slow the onset. This is basically increasing the exposure to blood, and again, the blood is basically a barrier between getting the drug from the lung to the brain. So higher pulmonary blood flow will lead to slower onset of action. And for example, if a patient has circulatory shock, this can actually lead to a faster onset of action. So just like the rate of onset of the drug action depended on the distribution of the drug from the lung to the blood to the central nervous system, the elimination is simply the termination of action is defined by the clearance from the central nervous system back to the blood, and then the majority of the drug is released through the ventilation. So for the most part, things that have a very fast onset are also going to have a fast recovery. Again, clearance by the lungs is a major route of elimination, and so again, insoluble drugs are going to eliminate at a faster rate. So for example, nitrous oxide will have a much faster recovery than halothane. And this is again going to be driven by how well they accumulate in the blood. It It's also true, though, that some of the more soluble anesthetics can accumulate in the blood and even into the tissues if given over a long period of time. So the longer exposure, the longer the recovery will be, particularly for the highly soluble anesthetics. There's also some metabolism by liver enzymes in the drugs that are well absorbed into the blood and the tissues, and so halothane and methoxyfluorine can form hepatotoxic metabolites. We'll talk about specific toxicities related to halothane and methoxyfluorine in a few minutes. However, things like isoflurane and desflurane are not well metabolized, and nitrous oxide is not metabolized at all. It's cleared and it's in the same conformation. So what we were talking about in the last few slides was what's going to drive the speed at which the inhaled anesthetics are going to reach their effective dose, and the blood solubility was the primary driver of that. Next, we're going to talk about the differences in the drugs with respect to their potency or strength, and the parameter that will define that is the minimum alveolar anesthetic concentration, or the MAC value. And this is roughly a description of the potency of the drugs. However, we don't really use an EC50 curve, a dose response curve, and derive an EC50 to define this potency. So in the classic sense, to get an EC50, you would perform surgery with a range of concentrations of the drug, and you would measure the anesthetic response. But obviously, the patients who get very little of the drug are not going to really enjoy their surgery very much, and the patients who are at the top end of the curve are going to be at risk of reaching that stage 4 medulla depression. So we kind of just guess at the middle of the dose response curve, and we do this with using a quantile approach. So let's walk through this. The MAC, again, the minimum alveolar anesthetic concentration, is the median partial pressure, so it's the average concentration of inhaled gas that's given to patients that results in 50% of the patients not having a response to some standardized painful stimulus like a surgical stimulation or a cut. So basically, again, we are just sort of approximating the midpoint of the curve using a quantile approach to define what concentration, and the concentration again is going to be reported as the percent of inspired gas, is going to result in 50% of patients not having a response to a stimulation. And so the MAC can be defined for each individual drug, just like each individual drug would have its KD value. In the case of inhaled anesthetic, each drug is defined by an MAC. So it takes 0.75% halothane as only 0.75% of the gas that you would administer to a person would need to be halothane in order for 50% of those patients to not respond to a painful stimulus. It takes a higher percent of sevoflurane to get the same response. So you have to give 2% of sevoflurane to 100 patients, give all of them a painful stimulus, and only 50% of them will have a response. Okay. So now let's look at what happens with nitrous oxide. So the MAC of nitrous oxide is reported as greater than 100%. So what does that mean? That means that it would require more than 100% pure nitrous oxide for 50% of the patients given that concentration to not respond. So another way of looking at it is if you give 100 patients 100% nitrous oxide and give them a surgical stimulation, more than 50% of them will still respond. And another way of looking at that is that 100% of nitrous oxide is less than 1 MAC as a unit of anesthetic dose. So what this means is that nitrous oxide, even though we said that it is very fast, it has low solubility, so it's very fast, and that's a good thing, it's actually not very strong. So even if you were to give 100% nitrous oxide, you're not going to have sufficient anesthesia in most patients. The other important thing to be aware of is that MACs are additive, so you could, even though nitrous oxide itself can't reach an MAC, if you add nitrous oxide to another drug, you would need less of that other drug. So in combining these different combinations and thinking about how their MAC values are additive, for example, if 0.75% halothane is 1 MAC and 2% sevoflurane is 1 MAC, if you were to combine 1% sevoflurane with 0.75% halothane, that would give you 1.5 MACs. Okay, and most patients for most procedures would require between 1 and 1.5 MACs. Another clinical consideration is that MACs tend to be lower in the elderly and infants, so the amount of drug needed would be less in these populations. And also when the inhaled anesthetics are combined with other IV anesthetics, with the opioids, or with sedatives, the amount required is significantly less. So you can use less of these drugs when they're combined with other things. So here is a table from your book that outlines the two key parameters that we've just been talking about. So the blood gas partition coefficient in this first column is going to define the speed at which the inhaled anesthetics get to the brain and start inducing anesthesia. So again, nitrous oxide, desflurane, sevoflurane, these are going to be very fast because they have low solubility. On the other hand, halothane has the highest solubility and would be the slowest. The MAC values shown here, again, this is not very well defined parameter. It reflects potency and efficacy to some degree. Because it's just a single midpoint of a dose-response curve, it's hard to specifically call it potency, but this is essentially a measure of the strength of the inhaled anesthetic. And so here, 100% MAC, this suggests that you would need more than is possible of nitrous oxide to have it be effective in half of the population in inducing anesthesia. So that makes this very weak anesthetic. And then moving down to halothane, you would only need 0.75% inhaled halothane to induce the same level. So halothane is slow but strong, and nitrous oxide is fast but weak. Okay, moving on to the organ system effects of these inhaled anesthetics. So in addition to the overall suppression of neuronal activity, and we know that all of these that enhance GABA A opening are going to have an overall inhibition of neuronal activity. There are also several other effects, and that's what we're talking about now. So starting with the cardiovascular effects. The inhaled anesthetics are going to decrease mean arterial pressure, and this is driven primarily by a reduced cardiac output for halothane and enflurane, and driven by decreased vascular resistance or dilation in the case of isoflurane, desflurane, and sevoflurane. Nitrous oxide has very minimal effect on arterial pressure. Halothane is going to cause bradycardia via vagal stimulation, and desflurane and isoflurane can increase the heart rate. And all of them can cause myocardial depression, but especially enflurane and halothane. Again, the least activity is seen with nitrous oxide. Finally, halothane can sensitize the myocardium to catecholamines, and so this can lead to arrhythmias in patients who are taking sympathomimetics, or in patients who are generating their own sympathomimetics by having high anxiety and having a sympathetic response. There are really significant respiratory effects of many of the inhaled anesthetics that have to be watched carefully. All of the inhaled anesthetics, except for nitrous oxide, can decrease respiratory volume and increase respiratory rate, but the overall decrease in respiratory volume is more predominant. So overall there is lower ventilation, even though there is an increase in the rate. This is going to lead to an increase in CO2 accumulation due to the lower ventilation, And so all of these drugs are also going to be general respiratory depressants with respect to the response to hypoxia, so the increase in CO2's ability to trigger respiration. The strongest effect here is seen with isoflurane and enflurane. Again, the least effect is with nitrous oxide. All of these drugs are going to depress mucociliary function in the airway. So the purpose of this function is to clear mucus in the airway, and so if this is depressed, it can lead to mucus accumulation and increased risk for infection. Most of these drugs can cause bronchodilation, especially halothane and sevoflurane, and this makes them very good induction agents in patients with compromised airways. So you're actually going to cause bronchodilation and allow deeper, more effective ventilation. The exceptions to that are desflurane and enflurane. These are both not good induction agents. Desflurane because it can cause airway irritation, cause bronchospasm, coughing, and breath holding. So again, this would, as a patient is beginning anesthesia, so they're still conscious, this is going to keep them from taking deep breaths and having that rapid induction. Similarly, enflurane is pungent and would keep patients from taking deep breaths and not get rapid induction. So things like halothane and sevoflurane that cause bronchodilation would be good for induction, particularly in patients who have compromised airways, so they wouldn't be able to take deep breaths otherwise. Desflurane and enflurane have the opposite effect. They keep patients from wanting to take deep breaths. In the brain, we again see an effect on this decreased vascular resistance or dilation. So this is going to cause pooling of blood and increase blood flow and cause intracranial pressure. So halothane is the worst here and would be very bad for patients with increased intracranial pressure. Having the least effect here is nitrous oxide. All of the inhaled anesthetics are going to increase the metabolic rate. Enflurane in particular can induce seizure-like EEG activity, and nitrous oxide, it's important to note that even though, again, it is very low potency, it does have high analgesic and amnesiac activity. So it has low potency with respect to loss of consciousness, but it does have significant analgesia and amnesiac activity. Finally, the inhaled anesthetics can decrease renal blood flow and hepatic blood flow, and with respect to uterine smooth muscle, the volatile anesthetics can potently relax the uterine smooth muscle, which actually makes them very useful in uterine or fetal surgery. So in a case where there needs to be a surgical procedure done to the fetus without delivery, the volatile anesthetics actually make it easier to manipulate the uterine wall to access the fetus. So as I mentioned before, there's a significant risk of hepatotoxicity with halothane, and in some cases can lead to hepatitis significant enough to require transplant. This effect is quite rare and may reflect a direct toxicity from the reactive metabolites of halothane, or could reflect an immune response to some of these metabolites. It's also been shown that enflurane can inhibit renal function, leading to nephrotoxicity. And finally, methoxyflurane has been shown to cause significant toxicity in the liver and the kidney and is no longer used. So a very significant toxicity that is rare but potentially fatal is malignant hyperthermia. And this is rare because it occurs only in patients who have a genetically predetermined sensitivity to inhaled anesthetics, and the mutations seem to be on ryanodine receptors. So ryanodine receptors are responsible for release of calcium from the sarcoplasmic reticulum. And so the combination of having this mutation and using the inhaled anesthetics in combination with neuromuscular blockers can cause increases in free calcium concentrations in skeletal muscle cells that are unusually high. And this in turn can lead to a severe muscle rigidity, muscle spasm, including hypertension, hyperthermia. And so again, this can be potentially fatal. It is treated with dantrolene, which reduces the calcium release, and also it's necessary to stabilize body temperature and electrolytes. Finally, another very specific kind of toxicity would be chronic toxicity. So for the most part, people aren't exposed to these drugs very often, very rare under surgical procedures, but the exception to that would be healthcare professionals who are administering inhaled anesthetics on a daily basis. So someone who works in a dental office or in an outpatient ambulatory procedure office who may be administering on a daily basis lots of inhaled anesthetics, so would have more of a chronic exposure. And the jury is still out on exactly what the level of risk is. There's some suggestion that there may be higher rates of cancer or miscarriage. And then there is also some suggestion that megaloblastic anemia can result from chronic exposure to nitrous oxide. But again, until this is completely understood, it just underscores the fact that proper ventilation is very critical, particularly to professionals who are going to be exposed to this on a chronic basis. Okay, so now moving on to the IV anesthetics. These are a diverse combination of different drugs that have diverse activities, obviously diverse structures. The barbiturates and the benzodiazepines you will talk about again with Dr. Franklin as sedative hypnotics, as anti-anxiety, anti-seizure drugs. And so the barbiturates, benzodiazepines, Propofol, and Etomidate are all going to have GABA-A mediated mechanisms. Again, ketamine has a unique NMDA receptor mechanism, and of course the opioid drugs will act at the opioid receptor. So starting with the barbiturates, thiopental and methotrexate are examples that can be used in general anesthesia. The mechanism again is to bind to and increase the duration of action of GABA-A channel openings in response to GABA binding, and also to directly cause channel opening at higher concentrations. So there is some evidence that these drugs can also depress glutamate activity. Again, glutamate would be excitatory, GABA is inhibitory, so enhancing GABA activity, inhibiting glutamate activity, both of these would inhibit neuronal firing. So in terms of their clinical use, the real benefit to the barbiturates is that they are very fast-acting and short-acting. So they will rapidly cross the blood-brain barrier and to get, again, very rapid induction of its effects. And also, once the drug is discontinued, it will rapidly redistribute to other tissues and is eliminated via a hepatic mechanism. So that makes it very good for induction. Again, our driving strategy here is we want to get to that surgical anesthesia level very quickly. So the barbiturates are also strong enough to be used for full surgical anesthesia. So they are not only fast, but they're also strong enough to completely cause general anesthesia. They have a very fast recovery. Methotrexate is a little faster than thiopental. And they can act as respiratory depressants and myocardial depressants. So they will decrease arterial blood pressure and cardiac output. So this would be potentially significant in patients that had existing respiratory or cardiac weaknesses. The barbiturates also can decrease cerebral metabolism and decrease cerebral blood flow. So this is, unlike many of the drugs we'll be talking about, this is actually good for patients who may have cerebral swelling or high intracranial pressure. In terms of toxicity, The barbiturates can reduce liver function temporarily and trigger a porphyric crisis, but this probably has to do with the fact that they are themselves metabolized in the liver. The second major class is the benzodiazepines, and the examples here are midazolam, lorazepam, and diazepam. All of these are also going to potentiate GABAergic inhibition, and they do that by increasing the frequency of GABA-A channel opening in response to GABA. But they do not activate GABA-A channel opening in the absence of GABA, so they are generally a weaker drug and have weaker effects. So in terms of their clinical use, one of the downsides of the benzodiazepines is that diazepam can require delivery in non-aqueous vesicles and be irritating. They also will have a slower onset of action than the barbiturates, and midazolam is faster than the others. And then also, again, reflecting this general weaker action, they do not reach surgical levels of anesthesia alone. So they can be combined with other things for surgical anesthesia, but they themselves are not sufficient. The benefits of the benzodiazepines is that they produce significant anterior grade amnesia, and including sedation. So they are commonly used preoperatively for that amnesia. Also, high doses can result in very long recovery from anesthesia, including a postoperative respiratory depression. So this can be a definite drawback and slow and potentially dangerous postoperative recovery. In the case of postoperative respiratory depression, the GABA-A antagonist flumenazole can be used to counteract these effects and normalize respiration, keeping in mind though that the flumenazole is very short-acting, so multiple repeated doses may be necessary. Okay, the next drug is not a class of drugs, it's a single drug, Propofol. It has a similar mechanism. It's going to potentiate GABA action and can also directly activate the GABA-A receptor channel opening. And it has become very popular and probably starting to replace barbiturates as induction agents. So the reason it is such a good induction agent is that it has a very rapid onset of action, and that's similar to the barbiturates. It also has a very rapid recovery, faster even than the barbiturates, has a very comfortable recovery, and this reflects the fact that Propofol has antiemetic activity, so it avoids some of the nausea post-operation, post-procedure. And so it's commonly used as part of a cocktail for general anesthesia, as both an induction agent and as a maintenance agent to maintain general anesthesia. It has been used alone for outpatient procedures, for very minor procedures, and finally it can be used for prolonged sedation in critical care patients. However, Propofol is not appropriate to use in children. It can cause an acidosis. Propofol does have some significant adverse effects and toxicity. So it has respiratory depressant activity similar to thiopentol. It can cause a decrease in systemic blood pressure, vasodilation, and decreased peripheral resistance. It has cardiovascular effects that are worse than Etomidate or thiopentol, in particular hypotension. We haven't talked about Etomidate yet, but the cardiovascular effects of Propofol are a major drawback. And then finally, Propofol commonly causes pain at the site of injection, and this is a major problem for the patients. And also, to a lesser extent, apnea, and causes some muscle movements. Propofol is cleared by a combination of liver metabolism and other mechanisms that we don't understand very well. And then finally, a newer water-soluble prodrug formulation of propofol called fospropofol has started to be used more widely. It has less pain at injection, which is the major benefit, but it does have a slower action. And the slower action reflects the fact that it must be metabolized to form the active form propofol. Okay, and the last of the GABA-mediated drugs is going to be Etomidate. So Etomidate is, again, a single drug. It potentiates GABA action. It directly opens GABA A receptors in the absence of GABA. And again, very similar to the other drugs, it's used for induction. It has a rapid onset and rapid recovery. Some of the things that make Etomidate unique is that it has no analgesic effects on its own, so it's going to be more focused on the loss of consciousness, and so it's typically given with opioids to block the intubation response. Also very unique to Etomidate, it causes minimal cardiovascular and respiratory depression. So it causes no change in heart rate, very little hypertensive effect, and makes it very useful in patients whose cardiovascular state makes some of the other drugs very dangerous. Adverse effects with Etomidate include pain on injection, post-operative nausea and vomiting, and a very prolonged infusion can lead to hypotension and some adrenal suppression and electrolyte imbalance. Okay, the next two drugs are not going to be GABA A targeted. The first that we'll talk about is ketamine. Ketamine is closely related to the hallucinogen PCP, and its mechanism of action is to block excitatory NMDA receptors. So since NMDA receptors are a fairly global excitatory receptor, blocking their activity will also lead to fairly global inhibition of neuronal function. So the response to ketamine is not a simple anesthesia or loss of consciousness. It's described as a dissociative anesthesia, and this includes catatonia, so loss of movement, loss of memory, amnesia, loss of pain sensation, but not necessarily loss of consciousness. So patients anesthetized with ketamine may retain consciousness. So for the clinical use, again, the main feature is that it does induce analgesia, so it can be used for some surgical procedures. It actually stimulates the cardiovascular system, so it increases heart rate, blood pressure, and output, and this is through sympathetic activation. And so this can make it helpful in patients that do have very weak cardiovascular systems. It increases cerebral blood flow, so again, should not be used in patients with elevated intracranial pressure. It decreases the respiratory rate, which is likely related to the increase in intracranial pressure. And then it has significant postoperative emergence reactions, so disorientation, sensory and psychic effects, hallucinations, and dysphoric reactions. These dysphoric features can be inhibited by prior administration of a benzodiazepine in addition to the ketamine. So ketamine is not widely used in the general population for surgical procedures or for general anesthesia, but there are a few populations in which it is very helpful. So in the elderly who tend to have very low cardiovascular activity, ketamine as a major general anesthetic or a component of the anesthesia cocktail can be helpful in stimulating their cardiovascular activity. Children are less sensitive to the psychic effects, so ketamine has been very useful in anesthesia for children. And then the most common use of ketamine is as an anesthetic in animals, so it's widely used in veterinary medicine. And then finally, the opiates, which we just talked about significantly as analgesics, can also be used for either a component or, in some cases, the primary anesthetic. So again, the mu-opioid receptors, which are the target of these opiates, are going to be inhibitory on lots of neurons. We focused on their inhibition of pain transmission, but obviously these receptors are going to be inhibitory in other types of neurons as well. So morphine, fentanyl, and other full mu agonists have been used in the context of general anesthesia. Typically they can be combined with nitrous oxide or benzodiazepines for moderate levels of general anesthesia. or for patients with low circulatory reserve. They can also be used as a pre-medication or induction agent, pre-medication and induction agent, or as an adjunct for other anesthetics. So for example, alfentanil and remifentanil have an extremely short, fast duration of action. Remifentanil has the fastest metabolism, so therefore the fastest recovery, and can be used for ambulatory procedures. And if you remember, the addition of an opioid is going to lower the MAC value required for the inhaled anesthetics like nitrous oxide. So opioids are also very useful in spinal and epidural applications and for post-operative analgesia. So again, they can be combined with these other anesthetics in many ways. Obviously, we've already discussed at length many of the adverse effects of the opioids in the context of anesthesia, that their ability to interfere with ventilation due to the rigidity of the chest wall is significant. And again, prolonged postoperative respiratory depression can be reversed with the antagonist naloxone. So just to sum all of this up, the clinical use of the general anesthetics rarely includes a single drug. An exception to this would be, for example, dental procedures where just a single administration of nitrous oxide may be sufficient, and that would definitely be an outpatient procedure. You can also have more, you can have combination administration for outpatient procedures, and so the focus here is going to be on drugs that can allow a fast recovery. You've got to get up and walk out of the facility that day, so definitely the short-acting IV drugs like thiopentol and propofol and possibly nitrous oxide can be used in combination. They all have fast onset of action and fast recovery. And then for longer procedures, more intense, deeper anesthesia would be necessary. And in this case, you would use a cocktail of balanced anesthesia. So very typically, you would start with a benzodiazepine used for pre-anesthetic sedation and amnesia. You'd have start with some of the faster onset IV drugs that are often used for induction, thiopentol, propofol, or Etomidate. And again, issues like cardiovascular disease, intracranial pressure would determine which of these were better or worse. You can maintain the anesthetic state with inhaled drugs, nitrous oxide or desflurane. And then opioids would commonly be used as an adjunct to enhance sedation, to enhance analgesia, and to manage postoperative pain. And then finally, neuromuscular blockers are typically used for muscle relaxation, typically depending on what kind of physical manipulation of the body cavity needed to happen during the surgery. And then finally, conscious sedation, where minor procedures where it's important that the patient maintain their lucidity. So sometimes during a procedure, the physician would need feedback, or if the patient needed to be able to maintain their own airways, you can use a combination of a local anesthetic with one of the IV drugs like a benzodiazepine, propofol, or the opioids. So again, the specific combination of general anesthetics that's used is really tailor-made to the surgical or whatever situation is requiring anesthesia.